Hi everyone, and welcome to our module on the vestibular system. So this is a drawing of the inner ear, and sound waves come in here, and this is the tympanic membrane, and here are the bones of the inner ear, and down here is the cochlea. But there is this portion up here which was named the vestibule a long time ago because it was thought to be the inlet to the cochlea, and at the time people weren't really sure what it did, but we now know that it's important for position, balance, and equilibrium. And that's the vestibular system that's found in there, and that's what we're going to talk about in this module. So the vestibular system is a central portion of the inner ear, and it's found within the temporal bone, and it's got our system for balance, posture, and equilibrium, and it also coordinates our head and eye movements. So when you turn your head to the left but your eyes stay focused on an object in front of you, your eyes have to move to do that, and that's a complex movement that has to be coordinated by the vestibular system. As your head turns left, the vestibular system has to detect that and tell your eyes to move right so that they stay focused on the object. You can really divide the vestibular system into two portions that do different jobs, and the first portion is called the semicircular canals, and these are these three loops down here on this drawing I've shown, and they detect rotation of the head in the X, Y, and Z planes of motion. So when you turn your head left or right, these canals detect that motion and respond accordingly. They're filled with a fluid called endolymph, and they have these little bulges at the base called ampulla, and the ampulla have hair cells that bend when you rotate your head, and the hair cells release neurotransmitters, and that creates an action potential that goes to the brain and lets it know that your head is turning in one of the three rotational planes, and it sends more or less signals based on the amount of motion so that your brain can detect how much your head is turning at any given point in time. The second functional portion of the vestibular system is the utricle and the saccule, and these are called the otolith organs. And these are over here on this picture. This is the utricle right here, and this is the saccule right here. They're little bulges in the vestibular apparatus. And these respond to linear motion, so gravity pulling you down or moving forward or backward. And they contain these little stones called otolith. Otolith is a Greek word for ear stones, and these are calcium carbonate crystals that sit on top of hair cells, and they drag the hair cells in response to motion. So inside these structures you have a series of hair cells like this with a stone on top of it, and when you move in a linear direction, the stone drags the hair cells this way or drags it that way, and this tells the brain which direction you're moving, and it generates vestibular neural activity. Some people think of these like the bubble in a carpenter's level. It sort of rolls left or right depending on which direction you're moving linearly. Once nerve signals are generated by the vestibular apparatus, they're sent through the vestibular cochlear nerve. And the vestibular cochlear nerve is two nerves in one sheath, the vestibular nerve and the cochlear nerve, which is important for hearing. The vestibular nerve sends signals to the brainstem, to the vestibular nuclei, and it also sends signals to the cerebellum, which is important for coordinating balance. The vestibular nuclei sit beneath the floor of the fourth ventricle in the pons and the medulla. They get input from the vestibular nerve, and then they have many outputs that I think it's fairly low yield to learn, but they do send signals to the cerebellum, other cranial nerves, and also to the thalamus. But what you definitely need to know as a medical student is what happens when there's dysfunction of the vestibular system. And the three typical symptoms that occur when this system doesn't work are vertigo, nystagmus, and nausea and vomiting. So vertigo is a sensation of the room spinning when the head is still, so it's motion when there shouldn't be motion. And you need to contrast this with patients who say they're dizzy or lightheaded. In actual clinical practice, when a patient says they feel dizzy, you need to really press them for more details to try and determine whether they are having symptoms of presyncope, which means lightheadedness, where they're about to pass out, or whether they're having vertigo or some other cause of dizziness. Nystagmus is a rhythmic oscillation of the eyes, and we'll talk about that a little bit in a few slides, but that goes along with vestibular dysfunction. And then the vertigo often causes people to get nauseous and have vomiting. So nystagmus is a very complex subject. There are entire books and volumes written on nystagmus. The easiest way to think about it as a medical student is to think of the two cranial nerves pushing the eye towards the middle of your head, and they keep the eye centered and they keep it focused on objects. And if one of these cranial nerves stops doing its job, what will happen is the other cranial nerve will slowly push it this way. And it's able to push it that way because this one is not doing its job. When the brain detects that slow drift to that side, it will quickly yank it back in the other direction. And that's what nystagmus is. A slow drift one direction and then a rapid correction back in the other direction. And you can see this on physical exam of people with cranial nerve 8 dysfunction because the eyes will have this rhythmic beating with a slow and then fast correction. So the reason nystagmus happens is because you have something called the vestibular ocular reflex, and this is what focuses your eyes when your body moves so that you can turn your head and keep your eyes focused on an object. Vestibular dysfunction disrupts this reflex, and that's why you get nystagmus. And as I said before, the eyes move slowly in one direction, and then there's a fast correction. So jerk nystagmus is nystagmus with that fast correction, and it's named for the direction of the fast correction. So for example, if this is the left side and the eye slowly drifts to the left but then quickly corrects to the right, you would call that rightward nystagmus because you name it for the fast correction. And so jerk nystagmus can be left, right, it can be torsional or rotational where it's moving in a clockwise or counterclockwise direction, and it can be upbeat or downbeat. Now there is a rare type of congenital nystagmus called pendular where it doesn't have a slow and fast direction, it's all one speed, but that's very rare and not something you're likely to see on your board exams. So this slide contains a very important rule of thumb for nystagmus. Left, right, and torsional or rotational nystagmus is seen with peripheral vestibular dysfunction, so problems with the vestibular apparatus itself in the inner ear. Upbeat and downbeat nystagmus is seen with central vestibular dysfunction, like brainstem lesions, like strokes, like tumors. And you need to remember this rule of thumb because you'll often be presented with patients on tests who have vertigo and nystagmus, and this will help you figure out the cause. We're going to talk more about this in the next few slides, but just keep in mind this rule of thumb. So when patients have vestibular dysfunction, they will come to their physician complaining of vertigo, and the physician's job is to determine whether it's a peripheral or central cause. And the reason is that peripheral causes are usually benign and central causes are often bad. Peripheral causes are usually an inner ear problem. The most common of these is benign positional vertigo or BPV. Peripheral vertigo can also be caused from vestibular neuritis and Meniere's disease, and we'll talk about all these in this module. The central causes are usually very bad things like a brainstem or cerebellar lesion. It can be a stroke or TIA. It can be an infarction or hemorrhage, or you can have a tumor in the posterior fossa, and this can give you central vertigo. So let's talk about the clinical features of central and peripheral vertigo. If you have central vertigo, which remember is the bad kind, you will have purely vertical nystagmus. So the nystagmus will be upbeat or downbeat. It will not be left, right, or torsional. Central vertigo gives nystagmus that changes direction with gaze. So when the patient is looking left, they may have upbeat nystagmus, and when they look right, it may be downbeat nystagmus. If you do positional testing where you lower the patient down onto the table and examine their nystagmus, you will get immediate nystagmus. We're going to talk more about this in a little bit, but there is a maneuver to diagnose benign positional vertigo, and it normally produces delayed nystagmus when you lie the patient flat. In central vertigo, the nystagmus is immediate. Patients can have something called skew deviation, where their eyes are misaligned. One may be slightly higher than the other. That's called skew deviation, and that's a sign of central vertigo. Patients with central vertigo often complain of diplopia, and they often have dysmetria. Dysmetria is where, when you do finger-to-nose testing on a patient, they can't touch your finger with their finger because they're off to the side or up or down. That's called dysmetria. And then patients with central vertigo often have other CNS symptoms, so they may be weak or have sensory symptoms or something else going on. Contrast that with peripheral vertigo. So peripheral vertigo usually has a mixed horizontal or torsional nystagmus. If you do positional testing where you lie the patient down on the table and examine their eyes, you will see a delay before the nystagmus occurs. So in a board question, they'll say the patient was lied down on the table and nystagmus occurred after a 10 to 15 second delay. That's typical for peripheral vertigo. The nystagmus may fatigue with time, so initially when you lie a patient on a table, you'll see lots of nystagmus and it'll stop after a few seconds. There's usually no other neurological symptoms, and they have normal proprioception and a stable Romberg test. All these are features of peripheral vertigo. So I mentioned positional testing in the last few slides, and the way you do positional testing in a patient with vertigo is to do something called the Dix-Hallpike maneuver. So this reproduces vertigo and causes nystagmus, and it's basically done to diagnose benign positional vertigo, which is the most common cause of vertigo. It's a peripheral cause, and it's benign, as the name suggests. So what you do is you seat the patient on the examining table, you have them extend their neck backwards and turn their head to the side, then you rapidly lie them down on the table. Usually the physician assists them lying down on the table, and you let their head hang over the end of the table while it's extended and turned to the side. If they have benign positional vertigo, which is the most common cause of vertigo, you will get a typical result. So what will happen is there'll be no symptoms for 5 to 10 seconds. Remember, symptoms and nystagmus are delayed in peripheral vertigo. Then they will say they're getting vertigo, they'll feel the room spinning, and then they usually develop torsional nystagmus. So this is clockwise or counterclockwise nystagmus. Don't get confused on board exams. They sometimes describe this as upbeat upbeat torsional nystagmus, and what they just mean is that it's moving up and then torsionally. But if it's got the word torsional in it, it's usually the benign form of nystagmus. The symptoms resolve when they sit up, and they have fewer symptoms if you repeat this maneuver over time. That's a typical result for benign positional vertigo. If you get anything that doesn't match with this typical result, then you have to be worried that they may have a central cause. So for example, if the vertigo develops immediately, if the nystagmus develops immediately, or if you see upbeat or downbeat nystagmus that is pure, that can all indicate a central cause of vertigo. So in the last few slides, I'll talk about some of these common causes of peripheral vertigo. And the first one is benign positional vertigo. It's also sometimes called benign paroxysmal positional vertigo, and it's abbreviated BPV or BPPV depending on which title you're using for the condition. And this is vertigo that occurs with head turning or position changes, and it's due to calcium debris in the semicircular canals. This is called canal lithiasis. So the debris in the canals moves those little hair cells and causes you to sense motion when you shouldn't be sensing it. You diagnose it by the Dix-Hallpike maneuver, which I just described, and if you get any deviation from the typical result of the Dix-Hallpike maneuver, as I said before, that's when you consider imaging, because there may be a central cause. What you're always afraid of when you're seeing a patient with vertigo is that they have a central cause being missed, so you want to make sure it's truly benign positional vertigo. And then there's a treatment for this called the Epley maneuver that can reposition the otoconia in the ear. It's somewhat similar to the Dix-Hallpike maneuver. You lie the patient back and then you turn their head as it hangs over the table, and you repeat this several times. A physician or a physical therapist can do it, and it repositions those stones in the ear and it makes the BPV go away. Another cause of peripheral vertigo is vestibular neuronitis. It's sometimes called labyrinthitis, and this is a neuropathy of the vestibular portion of cranial nerve 8 that usually happens after you've had a cold. It's usually viral or post-inflammatory. It's benign and self-limited, and I've actually had this myself a few times after a cold where I get a little bit of vertigo when I turn my head left or right. It's pretty mild and it usually goes away on its own. And then the last cause of vertigo we'll talk about is called Meniere's disease. So this is when you get excess accumulation of endolymph. It's called hydrops, and you get swelling of the labyrinthine system. So there are three classic symptoms for Meniere's disease, and you should know what they are. The first is tinnitus, so patients will complain of ringing in one ear. They'll have sensory neural hearing loss in one ear, and remember, that means the Weber is louder in the normal ear, and the Rene test shows air conduction greater than bone conduction. I discussed both of these things in the module on the auditory system. And finally, they have vertigo. So if you're presented with a patient who has ringing in the ear, hearing loss, and vertigo, they are probably describing Meniere's disease. The treatment is to tell patients to avoid high salt foods because this decreases the amount of endolymph in the ear. There are also a lot of triggers patients have for Meniere's disease, like caffeine and nicotine. So you tell them to stop doing these things. These are vasoconstrictors and they can block flow out of the inner ear. And then sometimes patients are given diuretics to try and lower the amount of fluid in the inner ear. And that concludes our module on the vestibular system.